Clinical vignette, acute intermittent porphyria, AIP. A 28-year-old woman presents to the emergency department with severe abdominal pain, nausea, and vomiting for the past 24 hours. She reports feeling anxious, confused, and having tingling sensations in her hands and feet. She denies fever, diarrhea, or recent travel. Her history is significant for similar episodes in the past, which were misdiagnosed as functional abdominal pain. She recently started a new oral contraceptive. Physical examination, tachycardia, HR 110 PM, hypertension, BP 150 to 95 millimeters per gram, no fever, no abdominal tenderness, neurological findings, mild proximal muscle weakness. Laboratory results, test result, CBC and electrolytes, normal, liver function tests, normal, urinalysis, dark red-colored urine, porphobilinogen, PBG, in urine elevated. Question: which enzyme is most likely deficient in this patient? A. Porphobilinogen deaminase, PBGD, also called hydroxymethylbilane synthase. B. Uroporphyrinogen decarboxylase. C. ALA synthase. D. Ferrochelatase. Correct answer: A. Porphobilinogen deaminase, PBGD, also called hydroxymethylbilane synthase. Explanation: this patient presents with acute neurovisceral symptoms, abdominal pain, neuropsychiatric symptoms, autonomic dysfunction, and dark urine, which are classic for acute intermittent porphyria, AIP. Key features of AIP: acute episodic attacks triggered by drugs, fasting stress hormones, severe abdominal pain, but no peritonitis. Neurologic symptoms: peripheral neuropathy, confusion, seizures. Autonomic dysfunction, tachycardia, hypertension. Dark urine from porphyrin precursors turns darker with light exposure. No skin findings, unlike Porphyria cutanea tarda. Why not the other options? B. Uroporphyrinogen decarboxylase. Incorrect. Deficiency causes Porphyria cutanea tarda, PCT, presents with blistering photosensitivity, not acute attacks. C. ALA synthase. Incorrect. This is the rate-limiting enzyme of heme synthesis, but its deficiency is not a cause of porphyria. D. Ferrochelatase. Incorrect. Deficiency causes erythropoietic protoporphyria, EP, presents with photosensitivity, not acute attacks. Diagnosis of AIP: 1. Urinary porphobilinogen, PBG, and aminolevulinic acid, ALA, during attacks. 2. Genetic testing, mutation in PBGD, hydroxymethylbilane synthase. 3. No increase in porphyrins in blood or urine, unlike PCT. Treatment of AIP: avoid triggers, alcohol, fasting, certain medications, stress, hormonal changes. IV glucose and IV heme infusion downregulates ALA synthase to reduce toxic precursors. Symptomatic treatment for pain, nausea, and autonomic symptoms. Acute attacks of learning points. Acute painful symptoms, dark urine, think AIP. Triggered by fasting, drugs, barbiturates, anti-seizures, sulfa drugs, alcohol, OCPs. Urinary porphobilinogen, PBG, is elevated in attacks. IV glucose and heme ALA synthase activity, stopping attacks. Would you like another clinical